Welcome to PACT's Digital Health Series. I'm Dean Miller, the President and CEO of PACT, and we've got a great discussion ahead of us for the next hour on telemedicine. You think you know everything about telemedicine, while you're about to learn a little bit more than you might already know. I want to first thank our supporters and sponsors who are numerous. And for today's program, specifically want to thank Anexinet, Dwayne Morris, Independence Blue Cross, and SAP. As you all know, you are muted on this wonderful program, Run the World, but you can ask questions. So please use the comments box. We will monitor those questions throughout and get back to you with answers. The panel will go for about an hour, and then we're going to break into subject-specific roundtables. And our speakers have agreed to join and host those roundtables to get a little deeper discussion going, again, face-to-face with small groups about those topics. So we encourage you to join that. We'll run till about 10 o'clock and then break up. As a reminder, we have certainly a lot of programming, certainly for digital health, healthcare, and others. And we have some terrific upcoming events as well that we'll touch upon and highlight the healthcare sector. Please visit our website, philadelphiapact.com, to check those out. And for anybody who's in the enterprise tech space that's connected to healthcare, our forum conference is coming up at the end of April in person, April 27th. And again, check that out. We would love to have you join us. We will be doing more in person as this year goes on. So again, please stay in tune. Find us on social. Check out our website. With that, let me turn the program over to our moderator this morning. Our host is Matt Mevis, the Director of Client Partners at Anexinet. Welcome, Matt.
Thank you, Dean. Good morning, everyone. Appreciate you having me, and I'm looking forward to an exciting session this morning on a topic I think that really, whether you're in healthcare or not, really hasn't been able to escape you over the last couple of years, especially. So, as Dean mentioned, my name is Matt Mevis. I'm a director and client partner at Anexinet. If you're not familiar with Anexinet, we are a digital engineering and consultancy firm specializing across the IT spectrum. But from a healthcare perspective, we work with our clients around client and member portals, digital front doors, back-end integrations, and connected experiences to make a secure experience for customers throughout. We're headquartered in Philadelphia, and we've been here for about a little more than 2 decades. So we work with payers, providers, ACOs, and other health tech companies. So certainly an interesting space and a fun space to be in the last couple of years. Prior to Anexinet, I worked for a couple of data and analytics and corporate performance management companies specializing in the healthcare space around data quality, KPIs and scorecard management, and also mobile patient rounding. So Dean already took care of some of the housekeeping items. We're looking forward to this 60-minute session, followed by some roundtables. To get things started, wanted to go around the horn and introduce the panelists. We have a great group and a diverse group here from an experience perspective, so should make for a great discussion. So to lead off, we'll start in the top left. Colin. Colin, did we lose you? All right, we'll give Colin a minute to get back. Jamie, why don't you lead us off?
Oop, Colin's back, but I'll start. Jamie Edwards, COO of Startup Health. New seat I'm sitting in. Startup Health is one of the world's largest digital innovation ecosystems in healthcare. Currently over 300 plus companies in the portfolio, focused around 14 different moonshots. We are really focused on solving healthcare's greatest challenges. Before sitting in this seat, though, as the CEO and co-founder of a company called Cloudbreak Health. And Cloudbreak was one of the leading health disparity solutions companies in our country. Platform was deployed in over 2,000 hospitals, and the core focus of the platform was to bring language interpreters to the point of care for limited English proficient and deaf and hard of hearing patients. And then during COVID, expanded the capabilities on the platform to do things like telestroke, telepsychiatry. We launched a new use case called telequarantine. So one of the largest telemedicine companies that people probably had never heard of.
Great. Thank you, Jamie. Suba.
Hi, everybody. My name is Suba Aaron Javia. I am CEO and founder of Caroline, I'm also a practicing hospitalist and former associate chief medical informatics officer at Penn Medicine. The entrepreneurial world is actually new to me in the last few years. I've spent the last 15 years at Penn, as I said, working as a hospitalist, but also bridging the gap between frontline clinicians providing care, and the IT department designing, developing, and implementing the tools that we use to deliver care to make sure that they're actually developed in a way that helps make our workflow easier. In that role, built Caroline as an a solution to an internal problem at Penn, which is really helping teams work better together around patients so we make less mistakes. My driving mission really is that it should be easier to take the best possible care of patients, and providing technology and creating technology to do that. So after rolling Caroline out at Penn a few years ago, we spun it out as a company. So I'm now doing this as CEO full time and really passionate about as I said, providing tools for the providers so that we can take great care.
Great.
Excited to be here.
Great to have you. And then rounding us out, Colin, good to have you back.
Sorry about that. Ran into some technical issues apparently. But good morning, everybody. My name is Colin. I have the opportunity to run marketing and communications for Brightview Health. Brightview is a comprehensive outpatient addiction treatment program. Right now we have about 13,500 patients under care. We have about 57 centers across 5 states. So a pretty good spectrum of kind of urban populations, rural populations. And because we're outpatient only, we tend to skew a little bit more toward the underserved population, typically Medicaid and those types of patient populations. So just excited to be here. Looking forward to talking some telehealth and what we think the future holds.
Great. Panelists, it's going to be a nice discussion. And, we can probably talk about this topic for many hours. I know we only have 60 minutes. So we'll try to break it down in a few areas and certainly try to take any sort of questions that come in on the board along the way. But just to set some context for all the things that we're probably aware of or that certainly have been ever present in our daily lives over the last couple of years, there's been a telemedicine boom since, with the natural accelerator of the pandemic. And McKinsey and Company published some analysis going back to 2021 with some April 2020 early pandemic numbers where telehealth utilization soared 78 times higher than it had previously in February of that same year. So obviously dramatic acceleration of the usage. Since that surge, we have stabilized overall. I think the majority of folks are now back in person. However, at the same time, that stabilized number is still 38 times higher than pre-pandemic levels. So that signals adoption, acceptance, an attitude shift. And that's something that we'll get into across patients and providers and the impact that it has. Additionally, as you can expect with all of that dramatic usage and the opportunity there's been a VC investment in virtual care and digital health innovation over the last couple of years that's unlike anything we've seen in the past decade. So it was 3 times higher, the level of VC investment in 2020 than in 2017. On top of that, per Digital Health Business and Technology, telehealth received about $9.5 billion of VC funding in 2021 alone. That's up 111% year over year. Obviously, 2020 was already a pretty dramatic increase. So we're going to take all of that into account. Certainly, it's become a part of our everyday lives. And now with telehealth and telemedicine, consumers of that technology, whether they're patients, providers, whomever, they're expecting a digital experience that mirrors what they would experience across other digital channels. So to start off the conversation and to dive in with that context, Jamie, I think you have some applicability in the VC space, so some thoughts on that numbers and maybe just some initial thoughts on that cultural shift that we've experienced over the last couple of years.
Yeah, well, look, clearly COVID was a catalyst for dramatic change. I think if you look at the history of it, healthcare is one of the last industries to go through digital transformation. And there's a number of reasons for that. But, finance, automobiles, you look at any of the large entrenched industries in our country. And by the way, healthcare is $4 trillion of GDP. and growing. And so it's an industry that's ripe for change, but culturally has been slow to do so. There's always the excuse that healthcare is different, that lives are on the line. As an entrepreneur, those are excuses that always bothered me in terms of like really driving change. But I think what I've discovered is that healthcare is one of these industries that really changes from the inside out. And so you really need to understand the regulations, the payer models, and it's complex. And it's one of the reasons why I think Silicon Valley has had a little bit more trouble in terms of really cracking the code on building healthcare companies. And the great healthcare companies have really been built by people who were on the inside, saw a problem, people like Suba who are trying to fix it. So it's been interesting from that perspective. We actually have some updated numbers on healthcare investment. Startup Health has something called the Startup Health Insights Report. And there was $44 billion of investment in digital healthcare last year, which was twice the number of the year before and 10 times the number from 2012. So it gives you an idea of the capital that's going into the space. And you look at funds like Andreessen Horowitz as an example, and they raised $9.5 billion alone, one fund, to go raise, to go put capital work in biotech, life sciences, and healthcare. So it's pretty amazing. And I think what we saw during COVID was this catalyst of people realizing that technology was actually feasible and that necessity was the mother of invention. I think one of the things that I noticed more than anything else was the fact that we weren't using any new technologies. It was email, it was the phone, it was all these things that were already out there, already scalable. It's not like there was some new holographic technology that drove telemedicine to the front and center. It was the need. And it really allowed us to bring healthcare to patients on their terms, when and where they needed it, and allowed them to avoid what was at the time a very infectious location, which was the hospital. So as we start to go to what is the new normal, people have said the toothpaste is out of the tube, whatever analogy you want to use. Telemedicine's here to stay.
Yeah, great points, Jamie. Suba, I think you bring a unique perspective to that, being in the clinical, the medical informatics world previously, and now an entrepreneur yourself. So, how have you seen that cultural shift from both sides of the table, and especially on the provider side?
Yeah, thanks. Jamie made a lot of really good points. And I also am struck by how there's no new technology. That's actually, I think, been like a mantra of all of my work over the last 15 years is we need to take what we've learned in so many other industries and how they've applied technology and bring it into medicine. And I think we could have a whole nother hour to multiple hour conversation about why that doesn't happen. But you're right that the need really drove it. And I think what's interesting is the need has always been there. It's just that we were able to see the need more. So from my perspective, the experience that I have is that I've been working on a lot of needs in medicine that are hidden. And there have been, and that's errors, that's operationalizing work, making it easier for people to communicate and be on the same page with each other. It's another example of something that's always been there. Medical errors have always been a problem. I'm sure all of us are aware of some of the cases that have happened, which are really, bone chilling when I think about, how they've happened and how they've been dealt with. But these problems have already been there, and there are solutions for them. But until there's something that drives adoption of that solution, it's really hard to make that happen. And it's interesting that you said that it's from the inside out, because as a provider, I don't usually think of government regulations and payer, requirements as being the insider. To me, that's the outsider. But it does feel like that is really what drives a lot of it. Some perspectives as a physician in this new amazing era of adoption of telemedicine culturally, in the same way that now on the business side, it's okay to call in, it's okay to be on a video, it's okay to be at home and have things happening in the background. That was a tremendous culture shift that happened in business. And it is also now in medicine, a little bit less, but we wouldn't have ever dreamed of saying, sure, I'll just, do a telemedicine visit. Now it's not only the norm, but as you said, expected for a lot of patients. We're like, I don't want to have to go drive and wait half an hour and figure out parking, but also on the provider side. And, there's a lot of, as you know, burnout and people leaving the field. A lot of women in healthcare have over the last 2 years disproportionately taken on family and other responsibilities. So leaving the house has been challenging. So being able to do telemedicine from home has been a huge, amplifier of being able to maximize on our workforce in an industry that doesn't already have that. The other thing I'll just mention, and then I'll pause, is that we were never taught how to do telemedicine. The people in medical school now, they are learning it, and it's been this huge growth in medical education. But, I didn't learn how to do an exam over Zoom. I certainly didn't learn how to tell you to move your arm so I can do the exam better. So just as there is a digital literacy challenge with many patients, there is definitely a digital literacy challenge with clinicians. And even just like thinking of it as a whole new way for us to examine and interact with patients. And sure, Colin will talk more about the connection part of it, but it's been interesting to see that growth in our field.
Yeah, that's great perspective. And Colin, to that point on your side, in your experience from an outpatient perspective, what kind of shifts have you seen?
Yeah, one of the really nice things about telehealth is that it allows us as an outpatient treatment provider to reach niche, high-need populations with care that's really catered to them. And so what that looks like is somebody who's in a rural environment who's LGBTQIA+, there's probably not a glut of people around there that they can get involved with, that they can do group therapy with. There may not be subspecialized counselors that they can interact with, or physicians that specialize in things like pregnancy care for pregnant women, those types of things. So what we're able to do via telehealth now is take people from kind of disparate communities geographically and bring them together to things like group therapy, provide them with dual certified physicians who are able to address both of their needs. Again, in the context of somebody who's maybe immunocompromised, somebody who might be pregnant and with substance use disorder, somebody who might have a cardiac condition and substance use disorder, and so on. So it's better for the providers because then they're not having to go to 5 different locations, one every single day, to treat different patient populations. It's also much better for patients because then if they're in a particular niche or they have some sort of subspecialty need, they don't feel as isolated. It's awkward to go to group therapy and there are 3 people that are LGBTQIA in that group therapy session. Well, now because we're able to really expand geographically and bring people in from all over, now there are 20, 30 plus people in these different group therapy sessions, which allows everybody to feel like I'm not alone, I'm not isolated, I am part of a larger community. And that the story sharing and all of those things that go into therapy are really, really important. And that's something that we weren't able to do 5 years ago. Well, maybe we were able to do it, but the technology adoption just wasn't there. So I think it's definitely improved the provider experience, and it's also improved the patient experience in some ways that are maybe not strictly medicine, if that makes sense, when we're talking about clinical care, counseling, and certainly medicine as well.
Definitely.
That's definitely medicine. I'm sorry, I have to say that. Like clinical care, counseling, talking to people, dealing with mental health, that is 100% medicine.
Agreed. Piggybacking off of that, Colin, traditional healthcare versus telemedicine, one and the same, but maybe not treated the same. So maybe just speaking to that broader continuum of care that we've now come to realize over the last couple of years.
Definitely. I mean, we've seen a shift from the provider side. What we thought required hands-on care, a lot of that can now be done via telehealth, and that's widely accepted. And then from the patient perspective, what they thought required hands-on care now has transitioned in a lot of ways over to telehealth, which is great. But it comes back to the convenience factor. People like things that are less expensive. They like things that are easier. They like things that are more convenient. And telehealth does all of those things. It checks all of those boxes. The challenge is when it doesn't, right? When you're working with somebody who's in a rural environment and they have connectivity issues. When you're working with somebody who has an out-of-date phone and the camera might not be as high quality. So what we're trying to do is kind of get around those issues and really serve patient populations that may not have the iPhone 13s and the 5G and the Wi-Fi 6 and all that sort of thing. So I think there's a lot of room for us to see what's going on in major metros and then expand that out into rural environments to better serve underserved patient populations.
Thanks, Colin. Jamie or Suba, would you like to expand on any of that, and maybe even just on the consumerization of healthcare that really people have come to expect, whether it's warranted or not?
Yeah, I mean, I think, and Suba made this point before, but I want to double click on it a little bit. Our whole health system has been built around the in-person visit. The infrastructure, the payment, like everything around it has been built around this in-person visit. But the fact as a gold standard, if you will, of healthcare, like, oh, I've got to go see my doctor. But the fact of the matter is the gold standard now is really chief complaint dependent. And a gold standard might be making a phone call and staying in your house or doing a video call from work, whatever it might be. And the whole idea is to establish what is a digital front door so that the patient can then wayfind the healthcare system more efficiently. And for lower acuity cases, do those from your home. Point in time in which they say, hey, I'm concerned about symptom X, Y, and Z. I'd like to make you an appointment. Like, that's the way the healthcare system should work. And if we were going to build a new healthcare system today from scratch, that's what we would design. So I think the fact of the matter is that we're stuck and we're entrenched in a little bit of our past. And look, entities and healthcare organizations, they have a biology, and their biology is to sustain themselves and survive. And a lot of that is really centered around revenue. So as we move towards value-based care, if you take a look at places like at Kaiser or the VA, who are really closed healthcare systems, but they manage the patient end to end. They do over 50% of their visits over telemedicine. And that was pre-COVID. So it gives you an idea of, if you're really trying to control cost, create a better experience, telemedicine really sits at the center of that. And, my whole goal for telemedicine is that we don't call it telemedicine. It's really just healthcare. And it's part of every doctor's toolkit or medicine bag as far as what they bring to the table in treating a patient.
Yeah, completely agree. I'll give you guys a perspective, which is that the phrase "a picture's worth 1,000 words" really applies in medicine. And the countless times before all of this, when people would say they had a problem or they would call me, just family and friends, I would say, I need to see you on FaceTime. And just seeing someone's face, how they're breathing, how they're talking, how they're holding themselves. I mean, there's 1,000 things I can look at and make sure that are okay or are not okay. Funny story is, as I went through med school and learned all these things, I would see people on the street like, oh, that person has this problem and this person has that problem, because we learn a lot just to diagnose visually. So there is definitely so much that we can do. I think things that we can do better that I've seen just magnify in the last couple of years is the tools that the clinicians are using from two perspectives. One is collection of data. So, we've had all this focus on the digital interface that we use to do the video conferencing or or even just the, phone conversations, making sure that's secure and everything. But a lot of what I need is data. I need vitals. I need, things that I need actual tools to measure. And that is something that, I think we need to do better on. We have a huge opportunity, and the technology capability is 100% there. That, hey, you have an Apple Watch, I can get a lot of information off your Apple Watch. But what I can't do is just click a button and bring that into my record. So being able to make it a lot easier to bring data from systems that are already in place and infrastructure that people already have in their houses so that I can use that in my clinical decision making is, I think, a real opportunity. And that applies also from a health equity standpoint in terms of reaching people who don't have internet access, not just don't have the ability to pay for it, but don't have actual access in their neighborhoods. There are companies, there are big shops, there are big places in those areas that do have access, and maybe we need to rely on some of that infrastructure that's there. And then the second thing is going back to how the clinical teams work together. And we already have insane numbers of communication errors, even when we're all in the same building in the hospital. It's even greater when we're taking care of patients across time in a clinic. But now when you make your clinic remote and separated by geography, separated by time, separated by system, you mentioned email, Slack, Teams, all these other ways, text, all these other ways. They're better than nothing, but they are not an efficient way to collaborate around patients. And I mean, imagine trying to plan a wedding on text message. It would be really hard. That's what it feels like to take care of a patient with all of these separate platforms. So I think there's a lot we can do in actually operationalizing and organizing the teams around patients.
Well, Suba, if I can piggyback on what you said with wearables technology and things of that nature, telehealth makes experimentation much faster and much less expensive than traditional means. So instead of me having to go to the board and convince them to open a new center or hire up a bunch of people or what have you to open, in Brightview's case, a full spectrum of psychology services and psychotherapy, what we were able to do is basically hire some psychologists and leverage telehealth to experiment with patients and make sure, okay, is this really valuable? Because one thing we run into is it's hard to find great psychologists that accept Medicaid. And we kept running into just issues with referrals and those types of things. So what we did is we decided to bring it in-house. And thanks to telehealth, we were able to experiment with that on a very regional level and then kind of blow it up now statewide and then expanding into other states. And the same thing is true with wearables technology, with more data analytics and so on, where now we don't have to go ask for these huge capital investments to buy real estate, to develop the real estate, to get it rezoned, right? Like we're able to do these types of experimentations and innovation in real time in a lot of ways with actual patients in a way that doesn't require this massive capital investment.
Yeah, it's true. I think innovation, rapid cycle iteration is something that we don't see nearly enough of in medicine. We see it in little QI projects. We see it in, some obviously clinical trial or, basic science trials. But when it comes to care delivery models, when it comes to how teams work together, when it comes to technology, it does not happen fast enough. It actually makes me insane. And it's so slow. It goes back to we could talk about this for 2 hours, but that is why healthcare is stuck because we don't have the ability to, and some of it's related to just security and privacy and all of the, baggage that comes with that. But, I can't just pick up my phone and download an app and start using it for my patients if there's any PHI in there. That's a problem. And it makes it really hard to make things better. If you guys saw a lot of the screens that we deal with in medicine, you would be shocked routinely.
Yeah, I don't think there was a ton of user design work that was done around EMRs and all those different types of things, right? I mean, you take a look at the world before EMR where the doctor would look you in the face and write his notes. And now instead of us, the doctor doing that, it's, oh, okay. Yeah, okay, right? Typing into the chart 100%. Or, trying to voice dictate. And it's just a much different experience. Like we've intermediated the patient-provider relationship with technology instead of using the technology to build connection, which is possible because I've seen it firsthand. So it really goes to that design component in a really big way. And one thing that Colin said that I think is really important to understand is COVID really showed the seams in our healthcare system from a health equity standpoint. And we talk about rural versus urban and rural being at a disadvantage. But the fact of the matter is there are medical deserts in some of our nation's biggest cities. I live in Los Angeles. Not everybody gets to go to UCLA and Cedars, but they go to that small community hospital that doesn't necessarily have the same resources. And so what do you do to level the playing field? Well, you use telemedicine to bring specialists in that hospital because that hospital wouldn't be able to recruit specialists in that community otherwise. There really are a lot of advantages. And we're still at the, early innings of this learning curve and deploying these tools into market. But I think one of the things that we're seeing, and, Suba, it was a great point when you brought up Slack and email and all these different channels, are these omni-channel models that really need to be thought more of as platforms as opposed to an amalgamation of point solutions. Exactly. And so you see hospitals and health systems now who are very focused on interoperability, bringing technologies in that have SDKs and APIs so they can create a unified experience. COVID we introduced all these things to market in a version 1.0 of what the telemedicine healthcare system could look like. But now it's time to build the next generation of that.
Yeah. So if I could piggyback on some of what you said, absolutely there's a usability problem in healthcare tech, and especially all of our foundational healthcare tech. And, I think it's important that meaningful use and high tech, it all had really great intentions. It was necessary. Delivery and how it happened, I'll not comment on at the moment just because I think people in many situations did their best. But we've learned so much. The way we as just a population consume digital information is completely different today than it was 5 years ago, 10 years ago, 20 years ago, and has changed. I mean, if you look at any website today compared to 20 years ago, they're completely unrecognizable. But EHRs are not. They are the same. and not just in their usability, but in the structure. So a lot of my work is around completely reimagining how we do written communication around patient care, because everything, as you said before, is built around the encounter, but we're providing care beyond just one encounter. My entire field of hospital medicine has come up because it's not enough to have your doctor come see you once a day in the hospital. Care is changing every hour, minute to minute, many times, but our systems are really still structured around a paper chart. And that's how EHRs are structured. They're literally structured around every person writes one note every single day. And so I'm actually studying this. The average patient chart has 15,000 words. That's half of Hamlet. And so when you think, well, didn't you see it? It's in my charts. Like, no, I'm sorry. I didn't have time to read half of Hamlet before I walked in the door. It's not possible. So there's a lot of work to do on that side. And I think you're right. In the same way, we need to do that with telemedicine. I forgot one of the other things that you said that I wanted to comment on, because I'm very passionate about the reimagining the tech part of things. But is it okay, Matt, if I answer one of these questions around what vital or what things people want on the RTM side, or are we doing questions after?
Yeah, absolutely. And Stu, I think you actually, we were talking about telehealth at the beginning being one of the most heavily invested areas. Well, data and analytics was number 2. So I think that's a perfect segue for some of the opportunities. Maybe touch on some of those challenges and the questions first.
Yeah. So, and actually this ties to what you just said about data and analytics, and I'll bring this in, Maggie, is that a lot of the focus for data and analytics is around claims. It's around administrative data. It's around pop health platforms, which are important. But what it's not doing is that last mile to the bedside, or the last mile to the physician provider or clinician providing care. And what I mean by that is, what's your heart rate? What has it been for the last 24 hours? I can see in the claims data that you had an MRI done of your head last week, but if I can't see the report and you're telling me that you're having a severe problem, I'm going to have to order it again. So when you think about value-based care, utilization is a real challenge if I don't have easy access to clinically ingest the information I need about you. So, data and analytics, I'm really glad there's been a lot of focus on it, but I think there needs to be more focus on clinical data and for consumption by the provider of care. To Maggie's question about the data that we need, I mean, some of the data, I guess you're asking the challenges about getting it in. Data that I'd like to have are the things that a triage nurse does when you go into an office, right? Is your vitals, your weight, your heart rate, your blood pressure, those kinds of things. As I mentioned, there's a lot of existing devices that can get a lot of that for us. There are all sorts of things we could do to operationalize getting those into the house. But then what? I'd probably have to have you read it to me off the screen. Be like, so what does the heart rate say? No, that's the pulse ox. That's not the heart rate. So give me the other number. I mean, the challenges are really around digitally bringing that information into the system that I'm using to care for you. And then when you think about all the channels that you were saying, Jamie, I need one view of your heart rate. I don't care if I'm getting it from your Apple Watch or your pulse ox monitor or some other device, or 10 different EHRs from 10 different hospitals you've been to. I can't adequately assess your heart rate unless I can graph it across all of those. That doesn't exist except for the work that some of us have done, but it's a big part of the work I do. Is to be able to make a good decision, I need to see your data integrated together around you. And right now, this was the other point that I was going to make, is that everything has been point solution, as you were saying, instead of thinking holistically, what do we need for the patient and what do we need for the provider to make that the healthiest relationship possible? And I feel like I'm monopolizing, so I'll pause, but there's a lot more I could say about that.
Well, at the end of the day, I think that's what's the desired outcome, is improving the patient experience, improving the patient's outcomes. You mentioned it, Jamie, I think earlier, healthcare has been a laggard. We've been falling behind. One of the things that has been more commonplace in other industries lately is around automation and taking advantage of that when possible. One of the other questions from the floor is, are hospitals currently utilizing BPA, business process automation, to connect those back-end systems and optimize some of those manual processes, which are repetitive? I think, Suba, you have a unique perspective for that, for some of the integration that you're working with Caroline. But Jamie and Colin, you want to start off with that one?
Yeah, I mean, the answer is yes. There are companies out there, one like Olive right now, who's doing a lot of back office work and using AI to tie different systems together and create virtual assistants, so that a lot of that repetitive work is being handled, and that kind of grinding it out every day, heavy lifting is being handled by a computer. That being said, it's not where it needs to be. I feel like, and this ties into a little bit of Suba's patient data discussion. The EMRs are treating patient data like they own it. And even health systems are doing that a little bit. And I would like to live in a world where the patient owns the data, the doctor logs in, submits their patient record. Like, how come we don't have a national patient identifier? This isn't hard stuff to do, by the way. It just takes some political conviction and someone to actually go out and execute on it. But a national patient identifier, patient record sits in the blockchain, and UPenn would log in, have their encounter, and it would be in there, and it would be there for every doctor to see, and the patient could grant access to the hospital when they show up. Like, these aren't new ideas. Suba's smiling, right? Like,
I feel like you're describing utopia. What?
yeah.
I can see everything I need to know about a patient. What?
But the funny thing is, like, it's not. It's there's a lift, but it's not like hard to execute from an actual technology standpoint. And so the big problem in healthcare isn't technology availability. It is people and culture of these health systems and culture of our government and everything else, and just our normal behavior patterns that are really blocking us from taking this next leap from where we need to go. So this ownership of patient data thing, I think, drives into that. And it's not like the EMRs have made it easy for patients to even get their data. I have a friend on Twitter, this woman, Stacy Hurt, who's a colorectal cancer survivor. And she's a patient advocate now. And one of the things that she has always talked about is, so I had to get my MRI from one doctor to another, and they gave me a CD-ROM.
That's standard. I mean, she's lucky that she got the CD right away.
And it took her like 3 weeks to get it, by the way. So yeah. It's one of these things where you're like, how are we still using fax and CD-ROM in an area where email and storage clouds exist? It doesn't make any sense. And we need to eventually take a really hard look at ourselves and say, look, it's time for us to make the required change to make this system better and more accessible.
Well, and Jamie, I'll piggyback on that a little bit because you're talking about blockchain integration and the tools are there, but we're still dealing with hospital systems and healthcare providers that are literally using faxes. Yeah. Like, we'll have a release of information form that someone has to print off, fill out manually with the patient, and then they'll fax it over. Versus, like, what we're trying to do is like push all of those people to DocuSign or some similar platform where it's not a difficult to use technology. It's very standard. You don't have to pay for it even, right? Like, we'll absorb the cost of DocuSign if needed for you to leverage that. But that prevents things being filed when they're incomplete because you literally can't submit it via DocuSign if it's not complete. So that prevents duplicate work. Hey, you filled out this ROI, but it was incomplete. Then you scanned it over. Now you have to do it again. You have to go back to the patient and have them sign something else. So I'll try to roll it back just a little bit. Like, yes, process automation is very important. Yes, leveraging blockchain can be done. We have the tools in place, but let's not put the cart before the horse. We're still dealing with a lot of people that are literally using CD-ROM, that are literally using fax. There's so much opportunity here for us to take medicine, not from the 1960s and the 1970s up to 2022, but like, let's get it up to 2015 at least.
Yeah. It's so funny seeing everyone's reactions to the fax and the CD comments. It makes me feel like the hospital and health systems, it's like a time warp when you walk in, because I will venture to say there is not one hospital that does not rely on fax and that does not rely on CDs. I mean, 100%. And that there is not one hospital, except for places where I've worked and have implemented Caroline, that are not using paper. I mean, have you all not ever seen your doctors writing on paper when you're talking to them? They also write in the computer, but especially in a busy setting and complex patients, people have to write on paper because the systems don't do what we need to do. And when we talk about BPAs, a lot has been done in a lot of different spaces. I think a really great example is Allergy Check. And you mentioned a lot of business, like back end, not frontline clinical care automation, which has been much easier to implement, I think, than the clinical side of things. A really good example of a clinical BPA that's happened is allergy checking. And I almost never have to even think about checking for allergies because I know the computer will do it for me as long as it's entered in properly, right? Bad data in means bad data out. So a lot of the teaching I do around safe practices and technology, and this is actually, I think you mentioned this earlier, Jamie, that we have to teach people how to use technology in an effective way with patients. One of those is you better make sure that the allergies are recorded well so that any medication that you order is properly checked. So we rely on the systems. That's been a great improvement. But where we haven't seen enough reduction in manual and duplicative processes is in the actual provider workflow. So the number of times that we write the same thing about a patient in one day, at least 6 times. I mean, if something's being written in email or on paper or in Slack or in a text message, it's not in your record unless you write it again. And then guess what? In your record, there's like 3 different places that you have to write it. So then, and that's just getting the information in. And when you think about blockchain and national patient record that I can just access, that first challenge is getting all the data in. Second challenge is making it available. The third challenge is how do I consume that data in a way that I can safely distill down and surface the information that I need to be able to take care of you. I'm going to bring the Hamlet thing up again because it's truly like finding information in a piece of paper on a book in a library. It's crazy. And that information could change your life, right? And so there's a lot of focus I think that needs to happen now on the clinician side of making sure I make good decisions for you based on the technology that I'm provided, which I, by the way, have no choice in as a physician.
Great points. And quick plug for the forum coming up, Philly Forum. Automation is the major theme of that conference this year. So certainly more to come. And whether or not, Subha, you mentioned it's on the clinician side, or even if it's the administration side, being able to provide some sort of streamlined experience, because overall that impacts the way the patients can access medical records or billing information or anything. So having some sort of automation, AI approach to help make things more efficient is going to help everybody. So we covered a lot there from an opportunities perspective and some of the challenges. We also talked about was health equity. And one of the opportunities there around 5G for remote areas is still maybe a concern. Colin, your thoughts maybe there from a health equity perspective, and just how the advances of telemedicine have almost certainly helped, but maybe even deepened the divide from a health equity side as well.
Sure. So the populations that we deal with specifically, we serve very, very rural, very, very poor communities, and we also serve very metropolitan areas. And so obviously the metropolitan areas have better access to 5G, to just general Wi-Fi connectivity in general. Think of like Hazard, Kentucky, or Henderson or Benton, Kentucky, where it's extremely rural, and so you don't have access to fiber optics. You, in a lot of cases, don't have access to reliable cell phone coverage, much less 5G. And so what we're trying to do, and what we've been able to do for Brightview specifically, is actually use our centers as places for people to come in and have telehealth experiences with providers that are in other geographies. So instead of you sitting at your apartment, or if you're housing insecure, crashing on somebody else's couch, or going to McDonald's or Starbucks where there's free Wi-Fi, you're able to come to a Brightview center and access the great internet that we have that's not fiber optics yet, but will be soon, hopefully. So that way you can communicate with other people in group therapy, so you can see a specialist and you can access other healthcare that you need. We're also starting to see in other states, Colorado in particular has been testing these basically like mobile units. So think of a retrofitted RV that has essentially a mobile hotspot that's able to bring high internet connectivity to underserved communities to provide things like telehealth and additional levels of care. So we're starting to see things happen and move in that direction. I'm sure Jamie can talk about the tremendous amount of investment that is going into projects like that to get Wi-Fi, to get internet access out to underserved and rural communities. But we're also seeing other challenges related to that, right? So you can come to a Brightview center and do your telehealth visit where there's reliable internet, but then what do you do with your kids, right? Like, who's going to watch your kids for 2 hours while you're at Brightview doing group therapy? And so then it gets into all of these other things. Do you have reliable transportation to get you from your current location to a Brightview center? So it's like it's like an onion, right? You see, okay, there's lack of internet connectivity in these communities. How can we solve that? All right, awesome. We check that box. Oh, well, now we have to figure out how to get people from where they are to the Wi-Fi connectivity. Okay, let's work through checking that box, because unfortunately, Medicaid transport is unreliable in a lot of situations. In a community that doesn't have access to reliable internet, they probably don't have the population density to support something like Lyft or Uber or another rideshare program. So then it's incumbent on the patient to figure out, how do I get childcare? How do I get transportation? How do I get transportation back from this location to my childcare, back to my residence, and so on? And so then we start becoming essentially case managers for these patients and trying to help them not just get safe and stable housing, not just prepare for jobs, but really figure out how can they logistically get to their appointments so that way they can see somebody who's in a different city anyway. So it's a very complex ecosystem, and we're working through it, but unfortunately there's no silver bullet panacea that we can come in and cure all with. But Brightview's making big strides in that area, and I know there are a lot of other treatment providers that are making big strides too. Something else I'll throw out real quick is we've seen over the last several years a lot of hospitals that serve rural communities be absorbed by much larger health systems. And so that provides better access to subspecialists, that also provides better access to technology in a lot of situations. So it's not just the individual specialized providers like Brightview with mental health, substance use disorder, and then all of the other litany of subspecialties. It's also healthcare systems and hospitals that are trying to step in and solve this problem too.
I think you called on Jamie, but I'd love to also say something about that.
Please.
A lot of times in the last couple of years, I've been involved in different, whether it's medicine or school committees. And what I usually see is that there's a subcommittee on health equity or diversity and equity. And almost every time I've participated in these, where we've gotten to at the end is, you guys, it doesn't make sense to have a separate discussion about diversity and equity. What we need to do is have that be a driving point in every single subcommittee, in every single project that we do. We need to always say, how are we making sure access is equal? How are we making sure that we're addressing all of these other challenges so that it's not just worked on in a vacuum? So that's my broad. I think you made a lot of great points, Colin. So I'll leave it at that. But the second thing I wanted to just add from a provider standpoint is there's so much work that's happening around social determinants of health. As you said, you end up feeling, and we're doing a lot of case management work. There's social worker work. There's people helping with transportation, people helping with food insecurity. And as a provider, I want to know these things. If I'm trying to manage your diabetes and make sure that you are on a good diet so that I don't have to start you on insulin, I need to know that you have trouble getting your insulin. I need to know that you have trouble getting access to non-processed, low-sugar foods, or that you don't have access to food at all. So that's another way that interoperability really needs to be improved, and not just discrete data interoperability, but inter-team, interdiscipline collaboration. And we can talk about channels of information. A lot of the work that we do with Caroline is say everything is around the patient. So think of it as like a project management tool. If you're a patient and you have this person helping you with transportation, and this person helping you with food insecurity, and this person helping you with, needing to get your medications, I want that all in one place, organized around you, so that then as a provider, I can consume that information. And too long in our industry, all of that is siloed. Even when you think about utilization management and case management from the payer side, I was talking to someone the other day and they were like, oh, well, I'm talking to the patient about exercise and why they don't take their meds. That's not stuff the provider wants to see. It's like, of course I want to see that. If they're having challenges with those things, they 100% affect my decision-making as a clinician. So, I think we need much more easy ways to be able to bring anyone involved in the care or the well-being of a patient to collaborate together around what they're doing and what the challenges are and what still needs to happen.
Yeah, so a bunch of amazing points mentioned. And Suba, thank you for bringing up social determinants of health. I mean, my view of the world is that SDOH is the future of healthcare. It's really the foundation of everything that healthcare is driven off of. And I remember during COVID hearing doctors say, wow, it was really interesting to be able to speak to the patient and see the video of where they lived, because that provided a whole new layer of context that you can't get in the doctor's office. You could see if their house was clean. You could see if they had pets. You could see if dishes were piled up and they, were stressed out and too big. Like there's a whole bunch of visual cues there that you could get that previously weren't available. When it comes to health equity, there's obviously this concept of the digital divide, which people are talking about with 5G and broadband and all those different types of things. But the thing we really need to think about is we don't want to take the existing healthcare system and port it to digital. Our existing healthcare system is already rife with bias, rife with process problems, and rife with health inequity. And so if we try and take our current processes and digitize them, I would argue that's the wrong approach because we're then burying the inherent bias into the system. And sometimes people will talk about this with AI. If you give an AI biased data, you're going to create a biased AI. So really important for us, as Subin mentioned before, to reimagine how we're doing all these processes and really take a fresh look and a fresh start so that we can address this health inequity. And one of the things that Colin mentioned is like they are operating both in rural and urban environments. Health equity is a universal problem that's throughout the healthcare system. And, it's interesting. I sit on the board of the American Heart Association here in LA, and they are working on all sorts of different SDOH programs. And I'm like, how does that have to do with the heart? But their view of the world is they're dealing with food insecurity. They are building gardens in the inner city so that people can have access to organic vegetables. And all of that is centered around being heart healthy and living a healthier life and existence. So it's interesting to see now that this has really risen to the top of the pecking order in terms of what hospitals, healthcare systems, and payers are really focused on. I think some of that was driven during COVID. Some of it was driven during the Black Lives Matter movement and the fact that DEI is now something that we're incredibly, a point of focus for every company across the country. And I think it's actually something that's really healthy for the healthcare system and the overall population that we now have this focus on health equity. And, my previous business, CloudBreak, it was 100% of what we focused on. We brought language interpreters to the point of care because these LEP and deaf patients fundamentally had a different experience in the healthcare system than people who could speak English. And so leveling the playing field was a key thing. And, Suba, if you're at Penn, the Marty platform that you guys use for interpretation was CloudBreak. So it was a key point of focus for us to then say, great, we solved this one health disparity. What else could we do on the platform in order to bring up and over that same platform? And then finally, there are companies like Unite Us that are out there. There are companies like Sir.
Oh no!
Did you guys lose me?
You did for a second, but you're back.
Yeah, just for a couple seconds.
So there are companies like Unite Us out there that are trying to tie together a broader kind of community-based healthcare patient record, if you will, that ties in community organizations and things of that nature into the patient record. There are companies out there like Circle, who most people don't realize that most pulse ox monitors don't adjust for skin pigmentation. And so they're wrong. So Circle has a ring now that the patient can wear like an Oura ring, but it takes into account skin pigmentation to give accurate pulse ox measurements. So these are all things now that are becoming the vanguard of how people should be thinking about health equity and practicing medicine.
I'll even simplify it a little bit more. Excellent points, Jamie, and appreciate the call outs for specific technologies. But at Brightview, something that we did, and this is really simple because the data should be in your EMR, is identify what factors, we call them protective factors and risk factors, right? Nothing revolutionary or exciting about that. It's pretty easy for you to say, hey, this patient has substance use disorder. What are protective factors? Do they have sober community? Do they have safe and stable housing? Are they employed, right? Like you can go through this checklist that says their protective factor index is 18 out of 20. And then over here, risk factors. Okay, does this person have safe and stable housing? Does this person have reliable childcare? Right? You can go through the list. Does this person have anxiety? Does this person have some other comorbidity, et cetera? And then that creates this delta that says their risk factors outweigh their protective factors or vice versa. And then what is the gap there? It's something that like we didn't have to bring in outside technology because we're already asking patients questions. It's just mining that data rather, and pulling that out to identify, hey, across the board, is this system perfect? Probably not, but it gives us a really good idea of what patients are very well protected and stable and what patients are on the opposite end of the spectrum, where maybe they don't have a lot of protective factors, but they have a whole lot of risk factors. So that allows us to say these patients maybe require a higher level of care. These patients maybe require more attention. Maybe these patients need other levels, other services that they're not currently getting. And that, I think, is really, really important, because serving a population is not just, hey, let's help you with your cardiology problem, let's help you with your pulmonary problem, right? It really is understanding what's the risk of, in our situation, relapse, what's the risk of recidivism, and so on. And so something as simple as just exporting that data from your EMR into Excel or Access or whatever analytics tool that you use. A lot of healthcare providers are very sophisticated, and they're using Looker and other types of business intelligence softwares, but you don't even have to get that sophisticated, right? Like, we do it in Excel, full transparency, and it's made a huge difference in us being able to identify patients that require more and or different care versus those that are really stable. And that helps us cross the equity barrier, because we don't want to be treating a patient who is very, very stable, has a ton of risk, or has a ton of protective factors and low risk factors, the exact same as we're treating somebody on the opposite end of the scale.
Yeah, great points. Yeah. And we could probably spend another hour on this topic in itself, but unfortunately we only have about 8 or 9 minutes left. So to close out, I would love to go around the horn. We've talked a lot of challenges, a lot of opportunities, but are we seeing some of those outcomes yet? And maybe it's too early to tell. Maybe we're still in the middle of the case study itself, but are we seeing some of those outcomes? If we are, where are they? If we're not, what are we missing? And then what does that mean for digital health and telemedicine moving forward? So Suba, maybe start with you.
Do you mean health equity outcomes or outcomes in general from telemedicine?
From a general, broader telemedicine outcomes.
Yeah. I mean, I think the two simplest things I'll say from outcomes or change is that telemedicine is still much higher now than it was 2 years ago, right? Or at all before. And I totally agree with you, Jamie. We shouldn't call it telemedicine, but healthcare provided, remotely, remote care is a much higher percentage than it ever was before. And coupled with that is the change in clinician or patient expectation and provider expectation. I think we've learned a lot in the last 2 years. It's been a great incubator of ideas and possibilities, but there is a ton more that we need to do. And a lot of these are things that we'll be talking about in our roundtables. But if I'll do my plug for the provider side, and I really mean clinician, right? So anyone involved in the healthcare team, I think it needs to be around the tools that we're using to support the clinical teams to be able to be in real time with each other, on the same page with each other, having the access that they need to data. As you guys think about all these different devices and all these different sources of data, imagine if you had to do your taxes and pull data from 20 different PDFs and then manually try to put them together. That's what it's like trying to take care of a patient and put data together. And then you wonder why people make mistakes. So, and if I could wave a magic wand, the thing I'd want to change is people not being so complacent about mistakes and errors that happen because of the cognitive load that clinicians are put under, and really prioritizing that. So that's where I'd like to see a lot of change happen.
Thanks, Suba. Jamie, from your perspective, I know you're seeing a lot from those, VCs that are collaborating amongst each other. Where are you seeing some of that digital health innovation and moving towards over the next few years?
Yeah, look, clearly if fund flows are a milestone marker on the highway of progress, then we're making a ton of progress in digital health. And I think fundamentally, with all of these investment funds raising money to deploy in the space, there's going to be a lot of innovation that is now funded in this sector. And, I think we could say it's actually working. I mean, there are a lot of evidence that healthcare is built around evidence-based studies, right? And there's been studies that say telemedicine reduces the carbon footprint. There have been studies that have shown that it reduces costs. There are studies that have shown that it provides, in many instances, the same quality of care as an in-person visit. So it's not necessarily about the evidence, because the evidence is there. It's really about changing practice styles, It's about properly reimbursing. It's about setting up the right regulatory environment and having some political conviction around really rationalizing the existing system, and streamlining something that is simpler, easier to access, more efficient, more affordable. I mean, healthcare is the number one cause of bankruptcy in our country. Like, what does that say about our system? It's really tragic. So I think we still have a lot of way to go here, a lot of room for improvement. But I, for one, am really excited about what the early innings of this digital transformation have shown and about its potential for the future.
Yeah, that's shocking, Jamie. And the other side of that coin, a lot of opportunity there, obviously. All right, Colin, closing thoughts from a digital health innovation standpoint, could be just within the outpatient world, but also just on a broader health lens.
Yeah, well, I'll look at this from a couple of different frameworks. One is acute versus chronic. So acute outcomes are a lot easier to measure, right? How many readmittance did we have on ACL tears? And it's easy to say, are we getting better or are we getting worse? From a chronic perspective, one thing that I actually look for in BrightView's data is I want to see us reaching worse patients, right? So patients who have fewer protective factors, higher risk factors, patients who are less stable, patients who are higher risk, those types of things, because that means we're reaching I hate to say worse, but we're reaching a higher need in the patient population. And so what we're looking at from a duration perspective, that's the real outcome that we're trying to measure. So over the course of 6 months from induction, what are we seeing from a PHQ, a GAD perspective, measuring anxiety and depression? What are we seeing from an alcohol consumption, from a substances consumption perspective? Measuring all of these indicators to say, are patients actually getting better? And what we're finding is that the quantitative data says, yes, they are getting better. And then I like to look at it from quantitative and qualitative. So talking to patients, hey, you feel like you're the only LGBTQIA plus person in Benton, Kentucky, right? But now you're able to get on Zoom and talk to 15 different people that have very similar stories to you. And the qualitative data outside of that is that people are feeling more connected, they're feeling less isolated. And so I think, yes, the quantitative outcomes are there, but the qualitative outcomes are very important as well. And we're starting to see those arrive as well, which is really exciting. And I think bodes very, very well for the future of medicine in general, but telehealth in particular.
Yeah, great points. Great closing thoughts. I want to thank you guys for all the contributions throughout in the discussion. It's a shame that it took a pandemic for all of this accelerated change, but on the flip side of it, we're certainly moving in the right direction. All the outcomes that we're already seeing, as Jamie mentioned, the evidence is already there, and the future is bright. Investment is, continuing to pile up. So obviously, there's opportunity ahead. So thanks to the panel. I learned a lot today. Hopefully, everyone else did at home. We'll certainly have an opportunity for you to connect with each of the individuals over the next 25 minutes. But certainly, we'd love to bridge those connections again going forward outside of the sessions today. So as we mentioned in the beginning, we have a few breakouts, and we'll have one panelist on each one of those breakout sessions. So the first one is Operationalizing the Virtual Office to Improve Efficiency and Outcomes with Suba. The second, How to Stop Competing for Patients with Every Other Telehealth Provider with Colin. And third, Digital Health Investing in a Post-COVID World with Jamie. So without further ado, I once again want to thank everybody for the time that they spent with the discussion. Hopefully everyone had a meaningful and worthwhile experience over the last hour, and looking forward to continuing the conversation to come.